Celia Morgan, talking about psychodynamic change
in ketamine treatment. Thanks very much,
Thanks.
Celia.
I'll wait for the slides, but that is really hard to follow. Jerry did the whole of the history of medicine, and Robert's done the whole of history of ketamine therapy, and we're literally talking about some very tiny, teeny studies here, so it's a bit of a change of tack. But yeah, so I'm going to talk about a study that actually Emily, who's sitting in the back, did for her dissertation, and Michael's going to talk about a study that was his clinical doctorate, so you're going to come up in a bit, I think. And so we're talking about psychological mechanisms of change in ketamine treatment. So hopefully I'll be able to interpret it in the context of the previous two talks, and just saying thank you to some of the people who are involved in this work. And this work, the studies were funded by the University of Exeter, but the drug was provided by Awaken Life Sciences and LTS Sloman. So it's oral thin film ketamine. So I don't really need to cover this again. Robert's done an amazing job. But talking about ketamine-assisted therapy and substance use disorders, because that's what I do for research. And interestingly, in substance use disorders, ketamine has only been given alongside therapy. And I guess that's because of risk, unlike depression, where it's been given on its own. And this is historically, and Robert spoke about those studies that moved from kind of aversion therapy, Evgeny Krupitsky's work in Russia, to kind of transpersonal approaches. And then recently, people like Elias Dakwa at Columbia and my group study, the Krabsky study, which sounded good until Rupert ruined it, where we had a psychotherapy control. We've looked in alcohol use disorder, and I guess interpreting it in the context of Robert's talk, because it was kind of trendy at the time, we paired it with mindfulness-based approaches. And these have kind of been quite dominant in the studies of adjunctive psychological therapy for ketamine. I mean, it could be because they're trendy. We're not proposing, obviously, that ketamine is like any sort of route to enlightenment. How we describe it to patients, and again, that kind of narrative is really important, is that the ketamine acts as this experiential stepping stone to help deepen mindfulness practice. So we know most people who've tried meditation that when you start out, it's really difficult and hard and boring, or I guess boring is hard. And someone said to me, I have absolutely no interest in what my own breath is doing. People get quite frustrated with the practice, and so it can be very demotivating at the start. But ketamine produces the states of consciousness, and other psychedelics too, I guess, that mirror those deep meditative experiences. And so we think they might be a kind of helpful illustration to help motivate practice, which can then promote engagement. And it's, again, these non-specific factors. So we think that might promote engagement with the practice. Also, particularly ketamine is really good at giving a kind of experiential insight into something called decentering, which is essentially the ability to view your thoughts and feelings from a third-person perspective. So to be able to think of your thoughts and feelings as events rather than truths about the self. And that's been shown to be really important in all sorts of treatment effects of particularly third-wave cognitive behavioural therapies, and really good for managing things like craving and substance use disorders. So those were kind of the processes that we wondered whether they were at play within these therapies. So we've been running these clinical trials of ketamine-assisted therapy, but not really trying to look at the different factors. So we ran this kind of small study, Emily ran this small study with harmful drinkers. So we just looked at 28 harmful drinkers. It says elf-guided. It's actually self-guided. There were no elves involved. That would be a DMT, according to the DMT researchers. Self-guided meditation practice. Even a psychologist don't employ elves. Over 14 days, so people came into the clinic. They learned how to do the meditation practice. And then we sent them away. They did some baseline measures, sent them away, and they would send a meditation practice every day. And they came back after 7 days, and they did some other measures, and we gave them either ketamine or placebo. They went away again, did some more practice, and came back at the end of 14 days. And what our kind of primary outcome, although it wasn't a clinical trial, was engagement. So we're looking at how much people engage with the mindfulness treatment, just as out of kind of interest, because it's been something that's suggested to be really important. And then looking at other factors, things like alcohol craving, depression, well-being, anxiety, and mindfulness. We found, so this is just on the CADS, we found this oral S-ketamine really robustly increased dissociative symptoms. We weren't that fussed about, our ketamine as long as it kind of produced this experiential state that would give insight into decentering. And then we found in both groups, actually, so we found a robust placebo effect in depression. They weren't a particularly depressed group because they were just people with mild alcohol use disorder. But their depression, both groups, reduced over 14 days, and their mindfulness on a mindfulness state scale and well-being increased over 14 days. There's no effect on anxiety. And then when we found interactions, there's just a small study, and we found in both groups, over the first 7 days, as they were doing their mindfulness practice, their alcohol craving decreased. But following ketamine, there was a further decrease in the ketamine group that was significantly different from the placebo group, who had a kind of bit of an increase in craving, probably, just prosaically interpreting it as maybe disappointment that they didn't get the ketamine. But then both groups had a significant reduction in craving evident at 14 days. So they were both significantly reduced compared to baseline in terms of alcohol craving. And what we did show is that, particularly in the ketamine group, though, who had received ketamine, that they did show this massive increase in engagement with mindfulness practice. So the number of times they'd access to practice, their motivation to practice, measured on this scale. So we thought that was kind of interesting. Again, it's not a very specific effect, but we'd shown actually that there were changes in alcohol craving in both groups, given just 14 days of this very simple guided home mindfulness practice that was based on mindfulness-based relapse prevention, which I was quite surprised to see. And also we found that this S-ketamine, just a simple dose of S-ketamine, increased engagement with the mindfulness practice. So it's not clear how this is mediated. Is it something motivational? Because engagement encompasses all sorts of things. Is it intentional? We could say expectation, that the ketamine kind of primes that, and then that engages them better. We could go down when we're talking on different levels of narrative and say maybe it's a neuroplastic change that increases their cognitive capacity. And it could be also perhaps this idea of an experiential stepping stone. So having that feeling of being separated from your thoughts under the ketamine enabled them to engage with the practice a bit more. So that on the topic of decentering, I'm going to hand over to Michael, who's going to talk about his multiple single I'll probably hang out here. Is that going to intimidate you if I hang out behind you?
Yeah.
I'll sit back down.
As Celia was saying there, I had the opportunity to do a very small clinically relevant ketamine study as part of my training to be a clinical psychologist last year. To try and test this potential synergy between mindfulness and ketamine in a small sample of harmful drinkers. So the primary aim was to investigate whether decentering represents a post-acute psychological mechanism of change. Because it was a small study with only 4 participants, I also had the opportunity to kind of qualitatively explore the clinically relevant acute experiences at a kind of psychedelic dose. I've inserted that image there to just really illustrate what we're talking about when we're talking about decentering, or we could use the term cognitive diffusion from acceptance and commitment therapy, or maybe even mentalization. There's loads of terms in the therapeutic modalities to represent the distance that we get from our thought process and how this can reduce our affective experience and allow us to respond in a more flexible way. So I used a single case experimental design. SCEDs, they're called. They come out of behavioral analysis and are designed to test the causal effect of an intervention at the level of the individual compared to baseline. Where the control group is the comparison point in an RCT. In single case design, the individual's baseline acts as the control and the behavior is measured from baseline to the introduction of the intervention. Therefore, the emphasis is on repeated measurement over time rather than across a group of individuals. There are many types of SCED design, but I chose a multiple baseline. And this is an example of a multiple baseline where the intervention is introduced at different points along the baseline. So if you've got longer baselines, then you can be more sure that you're observing the true effect. Can I go down a little bit? There we are. So moving on to the study protocol. Because I used a daily diary method, which delivered self-report measures via phone app every day, it was easy to meet the minimum measurements per phase required to get the power for a single case design. So there's a kind of standard of 5 points per phase. And that meant that I could have a powered study with a lower sample. So initially I wanted to recruit 8, but it ended up with 4. So after screening, 4 participants were randomized to one of the 4 staggered tracks, beginning with baselines ranging from 13 to 28 days. And then at that point, participants also began completing their self-report measures. After the baseline phase, then the intervention phase began with participants receiving the first of 3 ketamine dosing days, followed by a 90-minute integration session the next day. These were spread a week apart, and then on the final week, people just received the psychotherapy. And then that's when the self-report started, and then 2 weeks later, I invited participants for a follow-up interview. So anything else to mention on that one? Yeah. You'll notice that there's a higher dose of S-ketamine that was given in Celia's study that she described. So yeah, this sort of design, these SCEDs, they hinge on good measurement. So when it came to deciding how to measure decentering, I selected this 3-item self-report scale based off a recent factor analytic model of metacognition developed by Hanley and colleagues. But more importantly, the state scale was validated experimentally in a mindfulness intervention where decentering change mediated the relationship between mindfulness and treatment outcome, showing that it was sensitive to temporal changes, which is what I really needed to see for the kind of longitudinal repeated measurement aspect of my design. So they were the 3 items that were included in my primary measure. So yeah, participants were not patients. They were members of the general population, eligible if they exhibited harmful drinking, and excluded if they met criteria for alcohol use disorder, had uncontrolled hypertension, or a history of severe mental illness. Qualitative data was collected through my therapist notes, direct quotes of participant acute experience, and post-dosing, and something's going on with the screen. That's okay. I think someone's just making it more visible for me. Where was I? Yeah, self-report scales were measured using a slider visual analog scale from 0 to 100, which were presented randomly each day. Now, to reduce the priming or bias effect, secondary measures related to risk factors for relapse were added to the battery, including cravings, positive effect, negative effect, experiential avoidance, and then I kind of threw in a single item of awe just out of curiosity and in an exploratory way. Randomization tests were conducted to assess how likely it is that the results could be explained by the null hypothesis. We used non-parametric analysis to evaluate individual and aggregated effect sizes between the baseline and during treatment. Okay, yeah. So here we have the results for decentering. Participant 1, 2, 3, and 4. You can see that the blue line represents decentering. The vertical line represents the switch from baseline to intervention. The horizontal dashed line represents central tendency. The diagonal dashed line represents the trend line. And from visual inspection, there is some evidence that you can see of an effect. But this is caveated by what you can see, this kind of trend at baseline for a few of the participants, which I kind of interpreted as an effect of the intervention, an effect of, every day you're filling out these measures to ask yourself to step away from your thoughts. So something's going on there, right? But whenever we did the statistics, the individual tests were also non-significant. But however, whenever we combined the data, there was a significant increase in decentering from baseline to intervention with a large effect size supporting the hypothesis. Secondary measures, the same approach was applied. None of these, either individual or combined, returned significant results. The main differences were in the predicted direction, except for positive effect, which decreased, potentially explained by a loss of anticipation for the treatment or a loss of alcohol as a coping response. Of note, the largest effect size was returned for awe, but it should be noted that none of these measures they all lack the validity evidence for this type of design. So less confidence in these findings, really. So just quickly now to run through each of the participants' experiences in a qualitative way. So participant 1 was not able to reduce drinking in response to the treatment. She had a binge pattern of alcohol use stemming from her adolescent hedonistic days, which now seemed to kind of numb her emotions that came from a strained relationship with her partner, an unfulfilling job, and some family stress. She had, not that long prior to the study, achieved a year of abstinence through AA. Moving on to her experiences, they're very, very vivid feelings of connection and insight. In her final experience, she described something resembling an ego-death experience, which she said made a big impact on her. She said that it made her feel like she was propelling herself to an early grave. Of note, whenever I did the follow-up interview, she said that she felt that both ketamine and the therapy were necessary. And from the whole experience, she came away with a shift from self-criticism to self-compassion. Moving on to participant 2. This guy was kind of every night, 5 cans of beer a night for decades. The only abstinence period that he could recall was 1 month, 13 years ago. So he did pretty well. He was highly motivated, and alluding to what was spoken about earlier on, I really felt that he really believed in it. There was a lot of belief in it. But his experiences were interesting because the first one was quite underwhelming. That's what he said anyway. The second one was much more emotional, really profound emotions, and I got the impression that this was somebody who had been suppressing emotions a lot their whole life, and he was hard to build rapport with. And then after the experience, it just all came out, and there was a lot of grief that hadn't really been touched upon. And in his final experience, again, there was something resembling an ego-death experience. But his sister who'd passed away previously, who had alcohol problems herself, and the experience was something like them dying together into the ground, but she went on in and he didn't. But what he took from it was that, really, basically a lot of emotions. What's he said? He said in his feedback here, I'm starting to address suppressed emotions stemming back to my childhood. So he also made a kind of symbolic link in one of his experiences between this experience of having a bee and letting it go. And he volunteered to me that represented him letting go of alcohol. I'm more of a behaviorist, but I am interested in that sort of side of things, the sort of symbolic stuff. So then moving on to participant 3. She had tried various approaches to address her drinking in the last couple of years, but she really was at risk of losing her family as a consequence of her drinking it. She had been abstinent for a few months prior to the study, but was experiencing a lot of unstable emotions and strong cravings on a daily basis. Her first experience was a profound emotional experience, and to me it resembled the intense feelings of peace reported elsewhere in the literature. And there was also some evidence of personal insight and how she was reflecting afterwards about her self-destructive behavior. And then in the feedback, there was some evidence, qualitative evidence for the decentering, and her saying that it enables you to observe the landscape of your thoughts. Finally, the 4th participant. Again, she managed to, the treatment was successful for her in terms of alcohol. Her experiences were far less. I couldn't make much sense of them. I felt that there was some sort of block. They were quite somatic rather than visual. The final experience, I did feel that she was able to access some part of her that she liked a bit more. But really, I couldn't really make much sense of her acute experiences and how they related clinically. It was just I couldn't see anything there. So to wrap up, the design did show a causal relationship of decentering, but it's a very, we've no control, we've no blinding, there's loads of priming expectancy effects, but it definitely opens the door for future work as a mechanism that may facilitate or extend the effects of the drug. As noted earlier on, we cannot disentangle the effect of the drug from the therapy. And we probably need much better measurements to align our neurobiological understanding of these decentering aspects and dissociation. When I put together the post-acute mechanism with what I took from the qualitative experiences, I would say that there was evidence for decentering both self-report and qualitatively, but also things like insight and awe and emotional breakthrough were coming through. I think I'm going to pass over to Celia now for a summary statement. Is that right? All right.
Just to say,
21 seconds.
We've got 21 seconds, all right, to go. Yes, I just like this cartoon. It's basically, I suppose, back to what Robert and Joe were saying. I think it's a very early study, but showing that ketamine promotes engagement, and that might be a non-specific mechanism that we could harness in all different ways to look at engaging with different types of treatment. It also seems to be a powerful adjunct, or whether ketamine is a powerful adjunct or mindfulness is a powerful adjunct. It's kind of a mutual adjunct. They're both the charm, I guess, going back to that terminology. And I just put this here. The truth is there's more money in medication than meditation. I think people are quite wary to look at these kind of treatments, partly because of reservations about licensing pathways and things like that. But there is a history within substance use disorders, say, of labeling that includes therapies being recommended on the label, so with naltrexone and bupropion and buprenorphine. So yeah, just a nod there. So maybe not to be put off by looking at these combined therapies, but I think this session has given me heart that maybe we will be looking in more non-specific ways. So yeah, that's all from us. Thanks for listening. Down to 0 seconds. Yeah. Thank you.
Some of those moving experiences. There might be some questions.
Yeah,
about
I don't know if there's time for. There's questions for the elf? There's no time. Rupert's shaking his head.
Michael, could I ask you, when you got those observations, were they during the session, or people brought them up later when they've been thinking about it?
Both actually, and it was interesting to note, for example, that example I gave of the bee. So he described that straight after coming out of the trip. You know, this kind of psycholytic state where he's a little bit suggestible, maybe. Yeah. And then whenever 2 or 3 weeks later, whenever they conducted the interview, it was very much adamant. It was a very same narrative came through. So yeah, to me, it just felt like there was something in it. But who knows?
Yeah. Thanks very much. Okay, so.